Welcome to episode 11. This week we chat with Dr. Dar Dowlatshahi, a stroke neurologist and senior scientist at the Ottawa Hospital. Dr. Dowlatshahi is both an MD and PhD, has published research on intracerebral hemorrhage strokes that is referenced and used worldwide, and has some fantastic advice for young clinician scientists. He chats about his experience navigating through academia, where he thinks the future of ICH treatment lies, and the common pitfalls of young researchers. Enjoy. So welcome, Dr. Dar Dowlatshahi, to Behind the Numbers. I'm very excited to have you on.
Great, thanks. Thanks for inviting me.
So I want to start off, you're actually a dual doctor. You have both your PhD and your MD. And I want to start there because I know there are a lot of people who go into MD, PhD, but you actually started with your PhD and 3 years in, then decided to do your MD. What caused that decision? Were you planning on going into academia and then through your PhD realized you wanted to get into the medical field?
What was going through my mind? Is that what you're saying? Like, what was I thinking? Yeah,
Not enough school with a PhD.
I mean, it's the ultimate in not really knowing what you want to do with yourself. So just do everything, I guess. I was, I did my undergrad and I got really interested in neuroscience during my undergrad. And before that, as with a lot of people, you kind of always have in the back of your mind, apply to medical school. People in science, pretty much everybody's, if they tell you that they're not planning on applying to medical school and they're in science undergrad, they're lying. But it wasn't really something I wanted to do at that time. I really didn't know what I wanted to do. I mean, you're pretty young then, right? So I just kind of went with the flow, and I know I like neuroscience. So as I was approaching the end of my undergrad, I started looking at graduate programs to continue it. I just wanted to do more and get involved in kind of creating neuroscience research and producing science there. So I found a really good PhD supervisor in a program at McMaster. So I started in the PhD, and I was just basically doing what I liked doing. I was really enjoying my ride. I started with a master's and then switched to PhD after about a year and a half. And my supervisor was an MD PhD. He's now the Dean of Medicine at U of T. At the time he was at McMaster. And he was, he had a full clinical practice, but also ran the lab, and I was in the lab with him. And it was a good model for me, what he was doing, being able to see both the patient and the clinical side of it, get that context, and then go back into the research side and kind of develop the knowledge in the field. So he was very supportive and encouraged me to apply to medical school. So I applied probably my second year. Really, I was not expecting on getting in. That was not the plan. And I guess I got lucky on that one shot. I got in. And then now I'm doing my PhD, and I somehow got accepted to medical school. And what do I do? Because I didn't want to stop my PhD. And we did not have an MD PhD program back then. They have it now, but it wasn't a thing back then. So I actually deferred my acceptance. And I talked to the medical school, and they were open-minded about it. And they said, okay. And they let me continue along with my PhD. Once I put in another year, they couldn't hold it anymore. So then I had to put the PhD on pause and then hop into the medical program. And then I went back and forth. I would use my electives while other people are off doing interesting things. I was hopping back in the lab to finish my work. So I kind of did them concurrently. And I wasn't the first to do it. We knew this was possible because a few years earlier, one of the psychiatry residents found herself in exactly the same situation. So I knew that it was theoretically possible to do this, although there was no clear path. And every step of the way, you had to kind of explain yourself to both the graduate school and the medical school, what you're up to. But long story short, it happened. And I got both degrees at the same convocation in 2003. So that was kind of really cool. I got both my PhD and my MD at the same time. And since then, of course, they've now formalized the process so you can actually do both. But yeah, that's how that happened. It was just totally organic and unexpected.
I can't even imagine the workload. I mean, people struggle enough with just med school or struggle enough with just a PhD, and then not even having the program be integrated and almost doing them separately. That's impressive.
You know what? I actually think I liked it better the old way because it sounds like it's more work, but really it's not. It's more flexibility is what it is. When there is no rules, there are no rules, and that's
Yep.
actually depends on your personality, right? Whether you like structure or not. I was not a structure person, still am not a structure person. So I really enjoyed the fact that I could, as long as I could convince somebody what I was up to and they were okay with it, I could carry on and do it. And in terms of the workload, not really, when you're doing your master's as you are, that if it's something that you like and it's your project and you're carrying it forward, you don't see it as work, right? Yeah. You see it as ideas. You see it as kind of what you're doing that day. There is no you and then the work. It's always there. It's your brain. Basically, it's what you're thinking of. So no, it wasn't that much. If anything, the medical school side is a lot of work, but then this kind of becomes almost your hobby.
And when you started, when you started your PhD, like how did your PhD change a lot once you started the MD program and got the clinical experience, or did you kind of finish the topic you were working on in your PhD, and then once you left and graduated from both and moved into residency, did you start to expand on what you learned in medical school?
Yeah, no, it was, I left the lab basically because I did my PhD in a basic science area. When I went to residency, I really got into clinical research and epidemiology and clinical epidemiology. So it was a big shift. In terms of when I was in a medical school, I took that year of deferral to really finish most of the bulk of the work of the PhD. So it's actually really hard to do lab work and marry that with clinical work, because lab work is very time intensive and it has a lot of rigidity to it. Like when you start a process, you have to finish it. It's time dependent, cost dependent. But when you're in the clinical side of things, to do clinical research and investigation and epidemiology work, it actually is more flexible in that it incorporates very nicely with your clinical practice. So it's not that it's easier research, but it's easier to do as a clinician is the way that I would look at it. So when I went into residency, I basically finished my lab work. And I was looking at something completely different. And what carries over from the lab to the clinical side of research is the thought process, the investigation concept. So the why is things like this, and how would I figure out a better way to do it, and that kind of questioning. That's all the same. So even though I wasn't playing with test tubes and whatnot anymore, I'm now playing with patients and with scans and with therapies, and so it's the same type of process when you design your study. Or you ask the question and then you try and come up with a proper design to answer that question.
Yeah, that's true. You have the tools and they're very, very transferable. And so then you came to do your residency at U Ottawa. And from U Ottawa, did you know at this point, I mean, you had done your whole sort of academic career in neurosciences, neurology. Did you know already that you wanted to work in stroke? Because I know you went to Calgary for your stroke fellowship. So I'm assuming you had an inkling that you already knew you wanted to specialize in strokes particularly at that
Not
point.
super early. I didn't actually. When I started residency, I had no idea. Again, I've never had any idea where I'm going to go and what I'm going to do. I just always figured it's going to be something in academia. And you mentioned earlier being a lifelong student. That's exactly how I feel. I still refer to what I do at work, at school. I'll still say the wrong words sometimes. I'll say, I got to go to school. And they're like, what do you mean you go to school? Oh, right, the university. I mean, work, the hospital, right? So I still think of it that way. And so it wasn't that I got into residency and said, I want to be a stroke doctor. I got into residency, I'm going to be a resident. That's what I'm going to be. And while I'm doing, my first year, I had an opportunity for a research block. And I just, in your first year of the program I'm in, it's 80% stroke. So it's what I'm seeing, which is what generates questions. So what I saw was a stroke question, and I designed a stroke study. And then that was my first exposure to doing a clinical research study. And then I did another one a couple of years later. Same thing. I'm surrounded by stroke. And then while everybody's figuring out what they like to do, I just naturally, my personality geared towards stroke, which is more of an action-oriented acute care specialty. And then the research follows with that. So not to belabor the point, but it wasn't I'm going to be this and then therefore create a research project. It was just literally, this is what I'm doing right now, and here's the questions I have about it. And that's what developed the research program.
That's nice you mentioned that, because I know a lot of the stress, I guess, going through even grad school or PhD or anything is feeling as though you have to have your exact project and what you want to do for your life set right away, and that everything has to be exactly on that point. So it's nice to hear that there's so much room to still just figure things out as you go, and you're not almost like tied down to this one specific thing.
Absolutely.
And then
You want to be basically flexible and open-minded. You're learning tools.
And then how was, once you went to Calgary, what made you then decide on Calgary for your fellowship rather than staying? I know you were in Ottawa for your residency, but where was that decision made?
Yeah, well, Calgary, I mean, it is a internationally recognized stroke training program, and in fact, it's gotten even more famous. I like to joke and say I was in Calgary before it got big, which isn't true, of course. I mean, when I chose Calgary, I chose it because it was big, but it got even bigger. I mean, Calgary, after I was there, has made major, massive practice-changing breakthroughs, and people follow the Calgary model and whatnot. So for me, the reason why I went there, it was basically what I was doing in my first and second year of residency, seeing these patients and doing these things. You're reading around cases, and I was reading a lot of papers that were being put out by Andrew Demchuk at that time, or I later found out had actually been his work much earlier. So I was a little bit behind him, but I was following all of his work, and I didn't clue in. But Andrew was, of course, in Calgary, and I didn't know that at the time because his papers were coming out of Texas, where he'd also trained. And then once I figured out that, holy crap, that's Andrew over there. Then another, very big prominent figure in stroke is Mike Hill, who I think you've had on the show, and Mike in Calgary too. And I'm like, holy crap, these two massive people in my field are just over there in Calgary. And then a third one, Sheila Coots, was emerging. I mean, she was just finishing a fellowship and making some big impact. And she's now considered sort of the world authority on TIA and minor stroke. And she'd come to Ottawa to give a lecture. And I remember seeing her work and then finding out she's also in Calgary. And I'm like, what is this place where everybody's at? And I got it, how do I get there? And so that's how it happened. I met Andrew in my third year of residency. He was connected by one of my supervisors in Ottawa, and Andrew agreed to take me on after my residency, and then the rest was history. I had a great time there, and I still work incredibly closely. In fact, tonight after hours, I'm going to be on a call with Andrew and a couple of the Calgary people again. So I can't get away from there. 10 years, 12 years. And I'm spending my evenings talking to them still. So
yeah, because we still do work with them. I mean, you were one of the sites for the escape trial that we learned about, and that was pretty massive. So that's an awesome collaboration to have sort of in your back pocket, to have this network of people. And how did you decide to leave that to come back to Ottawa?
Then I guess, I mean, so at this point, I've been in university for 17 years, to give you an idea. Okay. So that's a long road, and I'm wrapping up. So part of it is, of course, family reasons. I have my wife is from Ottawa, and we have a family network here. So that's critical. I just had a kid, or he was 2 years old at the time. And it's very important to have the full family support. You got to have grandma, et cetera. It's really hard to focus if you're divided like that. So that was key. The other reasons were so the way I always looked at it, Calgary was had a lot of big fish. I mean, it started with these massive famous people. In fact, it was started by Alistair Buchan, who's the Dean of Medicine at Oxford, right? So like you get these giants there. And so there's little me just after 17 years of training, popping out, starting to do some work. And maybe it's a bit of a cop-out, but you can be a little fish, in a big ocean, or a big fish in a small ocean. And that's what Ottawa was. So Ottawa had all the building blocks, all the opportunity, everything was there. And it had terrific research programs in a lot of related fields, such as the clinical epidemiology and the OHRI and the cardiac work, and just incredible work that was going on here. And in the stroke side in Ottawa was very big with Tony Hakim here, but all in the basic science area. And I'd already connected with Tony and done some work with him. So it had all this, but it didn't have a strong clinical epidemiology stroke research program at that time. It had dabbled, it had done some research, it had done a few little papers. If you look back at the history of it, there were papers, there were some really interesting ones, but very few and far between, one a year, maybe 2 year tops. And so it was a perfect opportunity to come back and get that sparked up and going.
Mm-hmm. Yeah, you definitely had a lot of room to grow here in Ottawa. And so
Mhm.
moving into your current research, I mean, you still have a hand in the acute stroke therapy with your collaboration, say with Calgary and whatnot, but you've really specialized in intracerebral hemorrhaging. And
Mhm.
my only experience with this is seeing it in trauma patients, but I imagine, I mean, how else can this sort of happen? Like, what is this?
Yeah, so this is it's basically the other stroke, if you will. Every time we say stroke, people think of a big blood clot, which is true. That's about it depends which country you're in, but in Canada, about 80% of the time is that. But then there's the other stroke, which is the bleeding stroke. So basically, a blood vessel ruptures in your brain, and it can kind of rupture for a variety of reasons. Often, a big cause is having a long-term hypertension that's uncontrolled, and it takes its toll. It's just basically a pipe that bursts. Stroke is really simple. You want to just think of it as plumbing. That's really what it is, and you got a pipe that bursts. And the problem with ICH, though, intracerebral hemorrhage, is that it's extremely devastating. So it makes other strokes minor in comparison. So if you look at the mortality in stroke, it's gone down dramatically. It's down to about maybe 15% or even 10% is the mortality. We're really good at keeping people alive. Almost all of that mortality is driven by intracerebral hemorrhage. And if you survive an intracerebral hemorrhage, so the mortality of an ICH is about 40 to 60% in the first 3 months. So it's a lethal disease. And if you survive it, disability rate is 80%. Okay, it's a small bleed is a very rare phenomenon where small strokes do happen. So bleeds are big, they're bad, and there's no cure. There's no cure. There's no treatment. We've done a lot of work in ischemic stroke, and we have fantastic therapies. Still continue to come out with new therapies, new approaches. Every couple of years, there's a big breakthrough. But ICH, we've been really struggling for decades to come up with a treatment. So this past 10 years has been great for ICH. We've learned a lot about the disease. That's where I've done a lot of my work. And we've really mapped out how these hematomas behave, and now we're better equipped to target them. And we're very hopeful that in the next 5 to 10 years, cerebral hemorrhage is basically going to be treatable just like all other strokes.
Yeah, so some of the big things, just to throw it out on here, that you've done. I mean, in 2006, you had a paper, and that sort of defined like hematoma expansion. So when there's the blood pooling, I guess I think it was at like 30, greater than 33% expansion, or more than like 6 milliliters of volume. So that's been used in a lot of ICH trials. And from my understanding, a way that you can see whether someone is hemorrhaging, say you look at the CTA and there's what they call the spot sign. So there's a little like bright spot, and that shows active bleeding. Am I correct in what I'm saying?
That's right. Yeah. So the spot sign is where I, in large part, did my work in Calgary. Andrew had already started that, and we'd been in touch, and we kind of built on that project, and that's where that came from. And I spent the next 12 years expanding on that concept. So basically, what we're doing is, I mean, you have cerebral hemorrhage, and people are just throwing treatment strategies at it and getting nowhere. So he said, let's go back and understand what this hemorrhage is. What is it doing? How big is it when it starts? How fast does it grow? Where does it go in the brain? What is it squishing? And then when a person shows up in the emergency department with a cerebral hemorrhage, you can't see it because it's in a skull. It's in a closed box. Mm-hmm. They still bleed. I mean, if you cut yourself on the arm, you see the blood squirting out. One guy's got blood squirting out, one guy doesn't. Okay, well, that guy stopped bleeding, so we're okay. But this guy better wrap that up quickly and do something about it. So you can't do that with cerebral hemorrhage because it's inside the brain and you can't see. You can do a CAT scan, but that's just a snapshot in time. So we're using these technologies now to actually show and prove that people are still bleeding and how much more they're going to bleed, but essentially trying to predict the future, right? So we're looking at the person using a snapshot in time with a certain CAT scan technology, these spot signs, CT angiograms, and trying to figure out what's happening to this person in the next 2 to 3 hours. What's happening in that brain? What's getting crushed? Where's the blood going? How much blood? Is it 6 milliliters? Is it this much? Is it that much? So that's where all the work was. So there's a predictive aspect of the work, trying to figure out the future and how this is going to go, which will then inform what therapy different people need. Then there's also what I would call the foundational work, or defining the units of measurement of cerebral hemorrhage research. So when you do research studies, this comes back to epidemiology. It's all about the basic epidemiological concepts and all the basic design concepts. What is your MCID? You know, how much effect size are you actually trying to get? What is the natural history of this thing over the next few hours even? What is going to happen, and how does that surrogate outcome measure for example, growth in a hematoma, relates to your actual outcome, which is to say, are you back at work in 3 months, or does it take 9 months, or what does it take? So all of these relationships were not mapped out. And so that was a large part of my work, and still continues to be a large part of my work, is mapping out all of these relationships. And when you have that, then you can properly design a clinical trial. So when we look at the clinical trials that come out, it's actually very humbling. I look at the design of them, and I see they're using the very numbers and the very parameters that I came up with Andrew back in 2009, and then validated here in a different population, and then expanded with my grad student Rhonda and et cetera, and Vignan, and came up with new ways of looking at it. And these are all being incorporated in the trials. So I'm not, in a sense, I'm never going to claim to be a trialist, even though I participate in trials, but I kind of contributed to the little components that they needed to build that trial.
Yeah.
And that's kind of a cool place to be.
Yeah, you have your hand sort of everywhere. It's not like one trial, but you're sort of in all of them based on this. And
you cannot get rid of me. I am everywhere.
Yeah, try defining expanding hematoma without you, eh?
It's creepy. I just show up. They're like, go away. I'm not going anywhere. I'm right there.
I think that's the best way to build a legacy. You got to do something that they just can't have without. Yeah. And you mentioned that there's no treatment for it. I mean, do you have any idea of what your next steps may be in trying to figure it out, or what potential next steps people are trying to take for treatment? Or is it still this unknown that you're just trying to pick pieces at and sort of make this puzzle, if you will?
Yeah, absolutely. So we have a very nice roadmap set up. I mean, first of all, you got to get the principle, and in all medicine, actually in all science, I think you absolutely have to be really simple and don't overcomplicate things. So basically, when it comes to stroke, I said already, it's plumbing. You got a burst pipe. When you got a burst pipe with water shooting out of it, what do? Find the tap and turn it off. That's the first thing. Mm-hmm. Tie up that pipe so it stops leaking, and then clean the mess up. And what that 3-type approach essentially is hemodynamic manipulation. Drop the pressure head by adjusting the body's blood pressure very quickly, very safely. And there's a whole line of studies in that area. Then you got to use a hemostatic factor, which is basically taping up the rupture site. So you got to get the hemostasis going, and it's very time dependent, and different hemostatic agents will have different risks associated with it. So you got to get the right one at the right time in the right patient. And then, of course, the cleanup, and that's analogous to surgery. You got to get in there possibly with a minimally invasive endoscopic approach, and then clean out the blood that you don't want in there, which is causing all sorts of injury. So those are the paradigms that are being tested, and we're starting to look at combining these different paradigms. And so right now, the big trial that we have going through Health Canada right now, and already gone through the FDA in the States, and I'll be the Canadian lead. It's out of the NIH down in the States with Joe Broderick as the lead on this, is giving a hemostatic agent hyper fast, less than 2 hours, where there's stroke ambulances. It can actually be given in the stroke ambulance once a CAT scan's done, and try and stop that hematoma from expanding in those first 2 hours before it even reaches a point where it becomes dangerous to the person. And then there's a whole layer on top of that of how much do you bring down the blood pressure during that event. And you can do some very interesting studies. For example, if you're doing blood pressure reduction studies in ischemic stroke, and you can show that maybe it doesn't help the stroke, but acutely it doesn't hurt the stroke, then you know that you could actually drop everybody's blood pressure in an ambulance before you even know if it's an ischemic stroke or a hemorrhagic stroke, because you already proved it's potentially beneficial in one disease and definitely not harmful in the other disease. So just treat them both. Treat everybody. So you can use these types of approaches, which is a cool part of clinical epidemiology.
I like your analogy of it being like plumbing. As someone who doesn't work in strokes or know much about stroke specifically, I know it's obviously not as simple as that sounds, but it's a very nice way of putting it into terms that is very easily understandable. So I like that. And you had mentioned as well the essence of time, basically, and how everything has to be done as fast as possible and how critical it is. And that sort of brings me to where we're at now. I mean, a recent paper you published talking about COVID, that a lot of people aren't presenting to hospital because they may be reluctant or hesitant of encountering the virus. And for the most part, I think what your paper sort of said was that the more acute or minor strokes are the ones that were not presenting as much. There were still generally about the same of ICHs, if I'm correct. But
correct, yeah.
The implications of those minor ones not coming in after, say, this pandemic's done, how is that going to implicate? Is everyone who's not coming in just going to be in horrible shape, to say, or?
Yeah, and in fact, that came to pass, unfortunately. So the paper, although published recently, looked at the data from last March, April, where the COVID shutdown just started and was at its worst. And these were all treatable, preventable situations. And there was just an example in stroke. We see the same problem across all diseases of medicine. All these early capture rates were missed because people were too scared to come to the hospital. And then in the summer and early fall, we saw a huge spike. And in fact, we're still seeing it, of all these potentially preventable events that are now happening. So there was a week there where I didn't see a stroke come through the emergency department, and that was last spring. And then in the summer, I was seeing 3 to 4 hot ones coming in every day. And you wonder, I mean, it could just be a statistical blip. No one's actually done the study and looked at it. Could just be a statistical blip, but it's very compelling that you get this drop in people coming in with what are preventable situations. And then a couple of months later, boom, a huge increase of just everybody having these strokes, and nothing to do with COVID. These are not COVID strokes. These are just strokes. And I'm convinced a lot of them we would have caught had they come in earlier with their first symptom, and we could have fixed their carotid or whatever problem it is that led to the big stroke. Absolutely. We're seeing the same with cancer. I think if we keep the eye on the literature, you'll see how there was a quote unquote drop in cancer rates during the COVID shutdown, which is, of course, patients didn't go get cancer screening and therefore no diagnosis. And now you're going to see a big surge in cancer diagnoses and, unfortunately, later stages of cancer diagnoses. These are all called the bystander effect, and very scary stuff.
And it's devastating to hear because we've had a couple physicians come on and they had mentioned, I mean, there were some in ICU, so different areas, but they had mentioned even in the ED and ICU that there was hardly anyone there during the summer. Like as a business perspective, like there was almost money being lost because they were preparing for this influx of people and no one was coming in and there was no one to treat. And it's unfortunate that this all comes back to say of course it is something to be aware of and to be safe with this pandemic, but the hospital was doing such a good job of keeping everyone safe. And it's unfortunate that so many people were still so scared to come in that puts them in a worse position than if they would have come in. And then potentially, like you said, it would have been preventable, treatable, and it would have been okay. And it's just, I think that's going to be one sad thing to look at in hindsight, is thinking how things could have been different. But I mean, hindsight's 2020, as with everything. Yeah. And now, okay, so the last one thing, I'm keeping you close to the end of time, but just one last thing I want to touch on that I kept thinking to as we were talking through this is another paper that you had wrote, and I love the title. It's called Experience, the Name We Give Our Mistakes. And I was going through it, and I think it is so applicable to absolutely everyone, especially majority of our listeners who are all grad students in some sort, whether med school, grad school, PhD, whatnot. And if you could just talk about that for a second, or I can lay it out however you want to do it best, but I just absolutely love the points that you made, and just sort of to not be the eager keener who says yes to everything and burns out.
Yeah, I mean, we went. I was asked. I've done a couple of these sort of mentorship type of lectures, and I was asked to write a paper of picking sort of just these tips. And what I did is I reached out to a good friend of mine at U of T, and then another one over in Hamilton to kind of get two other perspectives in there as well. So I kind of came up with. I think these are the kind of lessons I typically tell people regarding, you just got your first faculty position, and your first 3 years, really your first 5 years are kind of your critical time, but the first three are very critical. And what you need to be aware of, because if you're not, you can lose those 3 years, and then it's so much harder to get yourself where you need to be in your fourth and fifth year. So I went back and kind of looked at all these things that I wish I'd known in my first year, but I didn't, and I figured them out the hard way in my second year. So in a sense, I lost only a year, but I got back on track. And then I ran it by my colleagues, and then they kind of added to that and said, absolutely, I can see that. And then they kind of added some of their own components. So it's a paper that talks about how to get yourself launched, the things you need to do to really get going, how the mentorship and having a champion out there is critical. Because you also don't want to be saying yes to everything, but it's also very hard to say no, and you need your champion to say no for you. So it covers a lot of these different scenarios, including when things go wrong and when you finally hit a point where everybody does, and it's sometimes years later where you suddenly figure out that you may have lost your way, and then you have to figure out a way, okay, what did I lose and how do I get back, right? That's another strategy, because you absolutely can. So yeah, it covers a lot of that. And I have been asked to go around and give the talking. I think people relate to it a lot.
It's nice because it's not, although you wrote it for the junior clinician scientist, you don't have to be a junior clinician scientist to not vibe, but relate to the lessons in there, no matter what stage of life you're in. I mean, there's always the delicate balance of, should I do everything in this attempt to reach the top? And I liked one of the things that you had said in there was that you think that you're climbing this mountain, you're doing all these things, and you think that once you get that position, you're going to be okay and everything's going to be a balance. But then you get there and then you just got a whole new set of goals. And it's sort of the realization that the climb never stops and you have to find balance throughout it. And
that's right.
Yeah. So I really want to touch on that because I really, really related to that. And it gave me a little peace of mind reading it even myself. And just, I'm definitely someone who can get caught up in thinking I need to do absolutely everything to give me my best shot at whatever career I want. But sometimes that spreads us too thin. So
absolutely. You want to keep your goal in mind and be moving towards it, but you can't do everything. First of all, it's not possible, and that doesn't get you to your goal. And you do need a mentor to help you watch out for those landmines. The problem is you really don't know what's ahead of you. You know what's behind you, but there is somebody who is ahead of you, 5 years ahead of you. They know what's behind them, and what's behind them is ahead of you. So you need that mentor. Okay, people are often they misunderstand the role of the mentor. The mentor doesn't look at your work and tell you, oh yeah, that's a good study, try this different thing with your study. No, the mentor looks at your overall situation and then goes, your work's fine, but watch out for this. This is coming, and that's what you need. You really do need that. And if you can't get it locally, you got to get it remotely. You need it somewhere.
And one last thing I want to end on then is, what would you say is sort of a key thing to look out for the student or the med student or resident who's looking for a mentor, what they should look out for when they're trying to find someone who will be that great guidance throughout all that?
So that's a very important part of your career. I'm going to give you a couple of things you need to know. First of all, you don't have to have one mentor. Okay, this ain't the Sith where there's the Darth Lord and then the one person with him. You can have 8 mentors. Okay, you can have a different mentor for different things. One that's your mentor for lifestyle, one that's your mentor for the science, one that's for the balancing all the different roles at work. So you can have more than one, okay? And you should probably have more than one. So that's the first thing. Second thing is read about it. There are papers published on this topic, the how to choose a mentor. It's critical because there's a lot of pitfalls. Then that takes you to the third thing. There's a lot of people who think they're mentors, okay? And almost all of us will at some point have that person who thinks they're helping you, but they really are not. People are not all altruistic, and they're not all non-psychopaths. They're psychopaths, right? There's a good number of psychopaths, particularly in academia, a good 10% of us. I may be one of them. So you want to just be aware. I'm not telling you to be scared, but be aware of it. And you can change mentors. So if someone is giving you advice that just doesn't feel right, there may be a reason for it. They may be promoting another agenda that you're not aware of, and you may be getting manipulated. And that's where it's helpful to have more than one mentor, because you bounce it off someone else and they go, oh, that doesn't make sense. And that's happened to me, where one person said, you shouldn't do this, don't do that, don't do that. And I'm like, it doesn't feel right, that advice. And I run it by a different person who goes, what? No, do exactly the opposite what that guy just said, So, and then you're like, oh crap, there's something going on here. So that's lesson number 3. Just be cautious, and you'll know when you have the right sort of flow, because a true mentor is not interested in their project and their goals. They define their success by your success. It's almost a parenting relationship, right? Mm-hmm. You have bad parents who just have kids, so they have a target for their own anxieties, and their kids grow up to be wrecks. Mm-hmm. But then you got these parents who are willing to sacrifice everything of themselves so their kids do better, and the parent gets their return or feedback based on the accomplishments that the kids were able to do with the investment of the parent. That's how a mentor relationship is. The mentor says, you're my student, or I'm supervising you. Your success is my success. And so they put that ahead. And it's hard to find that person, but you can. Mm-hmm. And you can find them at different levels and different, as I said, aspects of your career, both personal and professional. But don't undervalue the roles of these mentors.
Thank you. I appreciate the breakdown of that into sort of 3 key things to look out for. I mean, I'm sure a lot more plays in as you're looking, and you'll have different questions, but I appreciate that. And I will definitely link your paper on the common pitfalls and just how to navigate being really in any sort of professional setting into the show notes, because I really enjoyed it, and I really related with it, and I think that a lot of people will. So I'll add that as well. But otherwise, thank you so much for coming on. I really appreciated this chat, and thank you.
Thanks a lot, Gabby. It was great to meet you.
Thank you. You too. Have a great day.
You too.
Thanks for joining us this week. I hope you enjoyed this episode in hearing from Dr. Dowlatshahi about his work and experience. If you want to read his paper about the common pitfalls encountered by junior clinician scientists, the link is in the show notes. I'd highly recommend this paper to any graduate student, not just the clinician scientists. The points are extremely transferable and will help anyone who is navigating the world of academia. Lastly, please rate, review, like, and leave us your thoughts. Thanks again, and see you next Monday.